Hey guys, welcome back to Sister SLPs to Be. I'm Sarah, and today I'm going to be going over treatment guidelines for motor speech. As a reminder, I'm not an expert yet. I just got an A in this class. So without further ado, let's begin this review. Just FYI, getting this information from the Duffy and Dorkins textbooks. Let's begin with the hierarchy of subsystem treatments. This is the order of systems you want to prioritize. So first is the resonation and respiration system, then is phonation, and then is articulation and prosody. Some key things to remember is that you should treat 2 subsystems if it's a mild case. You should also be making sure that there's a 75% improvement over the baseline score before you advance to the next goal. And if there's no improvement after 30 trials, you need to change the goal. Also, you should do a maintenance check every 5 sessions. So next we're going to go over treatments. I'm going to go over the big picture. I'm going to go over the forest. I'm not going to get into the individual treatments. It's going to be up to you to do the reading, to ask experts, to ask your professors. I can in a later video do a deeper dive, but for the sake of this, my goal is to give you a map so that you can navigate what the treatment looks like. In other words, I want to give you guidance of the forest and not the trees. In Tier 1, or your first priority subsystems, we have respiration and resonation. Each subsystem can be treated 3 different ways. You have medical, prosthetic assistance, and behavior management. But you can tell here respiration only has 2 of those options, prosthetics assistance and behavior management. Under prosthetic assistance, we have abdominal blinds / corsets, and we also have expiratory bonds and paddles. Under behavior management, to relax and offer posture support, you could use myofascial treatment. To stabilize respiratory support, you can do exercises using a water glass manometer, the Seascape, do controlled exhalation task, several more that I don't really understand. Muscle strengthening, you could use the breather and the MST machines to help with muscle strengthening, and to teach compensation strategies, you could teach frog breathing and neck breathing. So now we're going to move on to the other number 1 priority subsystem, which is resonation. There are 3 options for care here. We have medical, prosthetic, and behavior. Under medical, you can do the pharyngeal flap, which is a surgery. For prosthetic assistance, you could use a palatal lift, which is like a retainer, or you could use a nasal obturator, which is kind of like blockage of nasal admissions. Under behavior, you could do resistance training by doing continuous positive air pressure, CPAP. You could also do inhibition techniques, which include prolonged icing and several more. You could also do controlling emissions, and you could do that by using the Seascape nasometry, listening devices, and increase overall speaking effort. So now we're going to move on to subsystem Tier 2. So if respiration and resonation aren't a problem, you want to work next on phonation. So phonation has 3 types of treatment: medical, prosthetic, and behavior. So under medical, there's 2 types of surgery you could undergo: thyroplasty 1, and if that's not enough, you would do a retinoid adduction surgery. You could also inject rhodesis, which would, make your vocal fold larger so that they could touch. You could also do neuromuscular reinnervation, or you could do a Botox injection, which would last about 4 months and only specifically for spasmodic dystonia. Under prosthetic treatment, you could use an amplifier to increase the client's voice. You could also use a neck brace or cervical collar to physically press the vocal folds closer together, but most people don't like that. You could also use visual and auditory feedback devices so that the client can train themselves to speak louder because a machine is telling them they are not loud enough. So behavior must be subdivided into 3 sections depending if the phonation problem stems from hypoadduction, or ataxic dysphonia. So for hypoadducted, you could teach them effortful closure, phonation beginning of the exhalation. You could also teach digital manipulation, which is basically pressing your fingers to your throat to close the vocal folds. You could teach head turning and chin tucking. Again, that applies the pressure to the vocal folds. You could teach hard glottal attacks, or you could get certified in the Lee Silverman voice treatment and teach them how to speak louder. So if the problem stems from hyperadducted vocal folds, you could teach them strategies to relax them. So that could be through the yawn sigh, that could be through the soft vowel prolongation, that could also be through the soft voice onset, all ways to loosen the tension. So lastly, if the problem stems from ataxic dysphonia, you could do laryngeal timing and coordination exercises. So now we're going to move on to tier 3 of the hierarchy. So that again means if respiration, resonation, and phonation are not a problem, then you should focus on articulation and prosody. Articulation can be treated medically with prosthetic assistance or through behavior management. Botox can be used medically here, and that would help with the management of spasms. For prosthetic assistance, they can be treated through mechanical and electric devices. So for behavior, you could improve the orofacial control through using a bite block, the crossbar, the IOPI, which basically measures or records the tongue pressure, some stretching and relaxing exercises. It's just vital to understand that if you do any of these types of strength training, you immediately do a speech exercise so that it crosses over. You could also, again, use the myofascial release. You could use biofeedback through the EPG and the EMG. So the EPG is going to be that tongue one. So it measures, you put it on like the soft palate tongue, and it costs about $300 for each patient so that the patient can then see where their tongue's moving inside their mouth. Then you also have the surface EMG, and that one's going to be the one that you put outside the body, so like cheeks and like the chin areas, so that you can see, so the client can see how their facial structures are moving. Then, of course, you have what most SLPs or SLPs-to-be think of, the traditional articulation therapy. You also have MIT therapy, which stands for melodic intonation therapy, using the right brain and singing. You also have multisensory therapy, and you also have the traditional intelligibility drills. Last but not least, we have prosody, which is in the tier 3 of the hierarchy, but I've also heard it's important to just put it in with the other subsystems. Prosody is divided into prosthetic and behavior treatment. For prosthetic, you could use the metronome to help keep the beat. You could use delayed auditory feedback. You could also use the alphabet board, supplementation, but it shouldn't be the primary treatment. For behavior management, you could do tapping, visual feedback, rhythmic cueing, which has the same purpose as using that metronome. You could also increase the loudness. You could also teach breath groups and across breath groups, which is essentially teaching the client to take a good amount of breath and stopping at appropriate places. And there's also several contractive stress tasks, which includes basically following and imitating the SLP's imitation and also changing phrases into sentences into questions. So there you have it, a summary of motor speech treatment guidelines. If you guys found this video helpful at all, please hit that like, leave a comment, let me know some further deep dives you want. Please, it really helps. And hit that subscribe button. I'll be trying to get a video out every Tuesday. Good luck on exams, good luck on Praxis, and enjoy your break.